Jacques, and your pager rings and you look down and you see this number. Okay. And, part of neurosurgery residency is not just understanding the pathology and how to deal with it, but it's also dealing with other providers and dealing with being a professional. So I wanted to kind of go through this scenario a little bit. So Jacques, what do? You call this number back and the provider is saying, I have a consult for you, a new neurosurgery consult. And the patient is weak in the legs and urinary incontinence, and they want to know what to do next. So how do you respond to that?
I would say I'm on my way to see the patient.
That's it? No.
So first of all, if I will get more story, any kind of history of how old this patient is, history of past medical history of possible cancer, infections, comorbidities, how acute was the onset of the deficit, any associated symptoms like fever or weight loss. Because this, if he presented it like that, it's could be a actual emergency. So first of all, we get a good exam and also more history.
Okay. Yeah, I mean that's good. That's a good way to handle it. I think there's no right answer, but what if someone presenting with the ER resident says the patient has urinary incontinence, weakness, and there's also a history of weight loss over the past couple months of 20 pounds. What jumps to your mind first and foremost, and how concerned are you?
I would concern of underlying malignancy that could spread to the spine.
Yeah, good. And then is this something you're going to wake up the chief resident for at 9 p.m. on Friday night?
Why you say? I would call you for sure.
Good. All right, good. So you got to the root of my leading questions, and we're going to talk today about spinal tumors and have a discussion a little bit about the spinal cord anatomy and incomplete spinal cord syndromes. And then if we have time, which is unlikely, we'll talk about metastatic, some of the data behind dealing with metastatic spinal cord tumors. So just as a quick background, up to 20% of cancer patients in general have symptomatic spinal mets that are treated either with radiation or surgery. Up to 70% of cancer patients in general have asymptomatic spinal mets found on autopsy studies. And of those patients who have spinal cord mets treated, up to 10% have spinal cord compression. So going down the list, Georgios, what are the most common tumors associated with metastatic disease to the spine?
So we've got breast, I think is the most common, and lung, and then I think prostate, and then renal.
Okay. Any other ones that are common that we see here?
Also GI tumors and thyroid tumors are like down the list.
Okay. Jorge, any other ones that we see commonly at a center, a cancer center, like Sinai or some, a lot of tumor, maybe like a hematoma. Yeah,
you have the systemic ones, lymphoma, myeloma. I think melanoma also can spread very quickly to the spine.
Exactly. So the most common ones: lung, breast, renal cell, prostate, and the other ones definitely that we've seen here: myeloma very commonly, melanoma also. And then this chart comes from a study that was done in 1990, looking at the time of onset after whether or not the spinal cord disease was discovered before or after the primary cancer. And most commonly, it's discovered after. Spinal cord compression. So the primary tumor is discovered typically before, and in most cases, and this is the delay between primary diagnosis and onset of spinal cord compression. So in breast cancer, it's almost 5 years after the initial diagnosis. However, in lung cancer, it can be as little as 6 months. So most often it's discovered after the systemic disease. All right, Halima, next on the list. What is the most common mechanism of metastatic spread for these tumors?
Is hematologic.
Correct. And there's another there's another common mechanism of spread. Do you know what that is, and which ones maybe do that more commonly? Which pathologies? Not hematological, but
I mean, they could be direct spread.
Yeah. Yep. And which ones can do that? Which histology typically?
The systemic ones, like no, actually,
I think correct me if I'm wrong.
breast.
I think more prostate. I think prostate is the most common to do direct. Yeah, so you're right though, with hematological being most common. So presentation, Matt. So describe to me what kind of consult findings you're going to have when the ER calls. What common findings are you going to be consulted about for these patients?
Oh, when the ER calls, we need to be called about any sort of concerning bladder or bowel incontinence, any weakness, I guess primarily be lower extremity weakness given the locations, sensory changes, saddle anesthesia, and then certainly if there's any radiographic abnormality, you'd be called about, MRI read showing spinal tumor.
Right. I think you're missing one. That was a great answer. I think you're missing one that's extremely important. And we'll go with, go ahead, Matt.
Pain is that?
Yeah, pain, exactly. That's extremely common, probably the most common. And it's something that is not specific for this, but is relatively sensitive. I think you hit all those, gait instability as well. Now, Matt, explain to me, you mentioned a lot of different symptoms, and I think there's a distinction between radiculopathy and myelopathy. And so which of these, so you mentioned bowel and bladder, do you think that's more of a radiculopathy or a myelopathy?
That's gonna be more of a myelopathy.
Right. And so what about pain?
Pain is gonna be more of a radiculopathy, I believe.
That's correct. Also a little bit of mechanical, if there's instability, it can be mechanical as well. And so we'll get back to the kind of radiculopathy versus myelopathy in a second, but Matt, since you're on a roll, what are the most common locations of these in terms of the level of the spine, cervical, thoracic, lumbar?
Thoracic is the most common, then I believe followed by lumbar and cervical.
Yeah, so 70% thoracic. And why is that, do you think?
I think, well, part of it I think is a numbers game. There's the most thoracic vertebrae. And I think that some of it is due to venous drainage, given that most of them are hematogenic spread, as you said earlier.
Yeah, I think yeah, you're exactly right. So here's a brief diagram of what we're talking about here, and what we wanted to do with what I wanted to kind of have you think about with this slide is there is a distinction between myelopathic pain or myelopathic symptoms and radicular symptoms, and it's kind of it's very important to think about that, and especially in the lumbar spine when you may have weakness of a lower extremity, a foot drop or something, which may be reflective of a radicular symptom rather than a compression on the spinal cord. So thinking about those symptoms and matching it with the imaging is extremely important, as we'll get to. All right, so at this point when I was preparing the talk, I wanted to take a quick detour to talk about incomplete spinal cord syndromes. However, this detour ended up taking a significant portion of the talk. So what started as kind of a quick detour is more of an exit into a different talk altogether. So I think since I have a little bit short on time, I think it's good to kind of focus on this. So I wanted to talk about spinal cord anatomy, spinal cord syndromes, and especially in relation, I think it's very important when you're talking about spinal cord compression, identifying the tracts, identifying possible symptoms of spinal cord compression, and how we can potentially treat that, and especially in surgery, how we can prevent damage to these structures. So this is all extremely important for the boards as well. And I know the boards are coming up, so I figured I'd focus on this a little bit. So let's see, I'll go up to Abi now. Abi, so talk to me about the spinal cord anatomy. When we talk about gray matter and white matter, it's pretty straightforward, and especially on this slide, you can kind of see gray matter and white matter. What does that actually mean? Why is it gray and why is it white?
So gray matter is basically the cell bodies of the neurons, and the white matter is axonal tracts, you know, either going up and down or interconnecting within the same level,
Right.
in general terms.
Yep, exactly right. And can you, so it's labeled here, but we have the dorsal horn, anterior horn, ventral horn, and we'll get back to kind of the surface anatomy in a second. But you're absolutely right. The gray is cell bodies, and especially specifically the synapses that occur. And so one important consideration here is identifying the cross-sectional area based on level. So Abi, from left to right, can you name what you think are where these are? Cervical, thoracic, lumbar. So how about this one here? What's the cross section?
Yes. So that is a cross section. Looks like a lumbar.
Okay, and why do you say that?
Because I don't see the fasciculus, gracilis, and cuneatus separated in the posterior aspect of the cord, because you're lower down in the body.
Right. And so which one is going to be here?
So this would be fasciculus or gracilis.
Exactly.
It's taking
Okay.
from the lower extremity.
Exactly. Okay. And so how about this one here?
So that one is, I think that one's cervical.
Why do you say that?
This is just a shape, I guess.
Okay, that's
and also I think one reason, something I would reason out, is there's more white matter relative to the gray matter. So all the tracts coming off from the lower extremity, you know, as you get to the cervical cord, there's a lot more white matter running around the cord, packed. So that would give a good hint.
That is the one way to identify it. However, consider that these are all scaled appropriately.
Oh, okay. Oh, in that case, the cervical would be a larger one.
Exactly.
Obviously.
Right, and the cervical cord is a little bit more ovoid, whereas the thoracic is a little bit more circular. And then also the gray matter. What's this little divot here?
So
it's specific to the thoracic.
Oh, the sympathetic.
Yep.
Yeah. The axons of the sympathetic, the pre-ganglionic axons of the sympathetic chain.
Is there a specific name for that? You can phone a friend.
Yeah. No.
Alex?
The intermedial lateral nuclei.
Yeah. So you're right, Abby. It's what it is, but just remember the name, just so you can recognize that as potentially an answer on the boards. All right, so we'll start, Alex. We'll start with you. We'll go through these tracks, and so we already mentioned these are as Abby correctly mentioned, the posterior columns, dorsal columns. Can you tell me a little bit about what their function is, and also their course through from the musculature to the brain? Let's start with the function here.
Sure. So function sensory, more specifically vibration, proprioception. As Abby mentioned, gracilis of the lower extremities, and then cuneatus of the upper extremities.
Great. And then what do you think about the course? So describe the course from the lower extremity up to the brain. In terms of the first, second, third order neurons.
It's from the end organ.
Yep.
So from the end organs, entering in the musculature, then going in, following the dorsal rami, past DRG, over to the first synapse in the DRG, and then coming up through the dorsal columns, and then synapsing in the medulla, decussating to the thalamus, synapsing for a third time, and then up to the somatosensory cortex in the postcentral gyres.
Yeah, I would say that's very good. I would be a little more specific in that it ascends ipsilaterally like you said, it decussates near the medulla, but the first order neuron actually does not synapse in the DRG. It actually synapses up in the nucleus, in the nuclei, cuneatus and gracilis in the brainstem, and then the second order is from there to the thalamus. So unlike the spinal flammar tract, which do synapse, there is a synapse lower in the spinal cord. This one does not. And which do you know which, in honor of Dr. Coppell, which thalamic nucleus these route towards?
I believe the ventral posterior nuclei.
Ventral posterolateral nucleus. Yes. All right, and then the other important question about these pathways is their somatotropic organization. So you already kind of explained it. That medially is the gracilis, but be more specific. Like how is the homunculus arranged in the spinal cord and in the dorsal columns?
So sacral is most medial, and then going from medial to lateral is sacral, lumbar, thoracic, cervical.
Right. Exactly. Good. Okay. We'll bump it up, or let's go back to Jacques. So Jacques, Laura, let's talk a little about the spinal thalamic tracts. So there's two of them. There's anterior and lateral. And can you explain kind of the function and of both? And then we'll talk about the course of the neurons in a moment. So, but first talk about what anterior and lateral do respectively.
Yeah, the lateral spinal thalamic, it's for temperature and pain, and the anterior is more for sensation itself, touch and pressure in anterior, and lateral is pain and temperature.
Right, exactly. And important other things about the lateral is that the A delta and C fibers will cross through here, and they decussate at the level through the anterior white commissure, which is here. So the course.
So as you said,
well, let's skip this for a second. Okay, the course. I'll give you a little hint here.
Yeah. So as you said, decussate at the level of spinal cord when it enters, and then that go up to the, I can call it BPM, and then to the somatosensory and cortex.
Right. Yeah. So in summary, there is the cell body is in the DRG here for the spinal thalamic tract. The first order neuron is from the end organ to the dorsal horn here in the cell body. I'm sorry, and the first synapse is there, decussates through the anterior white commissure, and then ascends in the lateral spinal thalamic tract up to the thalamus, actually the VPL.
Okay.
And so that's the second order neuron, and the third order is from the thalamus to the cortex, to the sensory cortex. So talk to me about the homunculus here.
Yeah, the distribution is from medial to lateral. It's cervical, thoracic, lumbar, and sacral.
That's right. So yeah, opposite of the dorsal columns. All right, so we'll go back for a second and talk about the fibers. I won't ask this. This is a little bit in the weeds, but so C fibers are the smallest. You can see based on this, and they're unmyelinated. So that means they're unmyelinated, and it's really the dull pain and temperature. The A delta fibers are myelinated, so much faster, and there's more of the sharp pain. Sorry, a little bit slower. And then the A beta are receiving information from the sensory bundles, like the corpuscles, and also myelinated, and those are the slowest conduction. All right, so these are some important nuclei and tracts, so they're a little bit smaller. We'll bump it up to Jeffrey Zimmering. Tell me about Lissauer's tract. What do you know about it, and what does it do? And just give me a couple facts.
So Lissauer's tract is the white matter that enters into the dorsal horn for the first order neurons to synapse in the first relay of that pathway, and it basically runs throughout the spinal cord.
Mm-hmm. Yeah, so that's right. So it's gonna, this tract will ascend or descend one or two levels before it decussates. So the decussation of the spinal thalamic tract is not always right at that level. It can raise up or down a couple levels depending on Lissauer's tract. So how about the substantia gelatinosa, Jeff Zimmering?
The substantia gelatinosa is the Rexed lamina 2 layer of the dorsal horn, superficial spinal cord. It houses most of the nociceptor populations and the interneurons that are in that area. So this is where it's perceived most of the pain signaling for synapses within the dorsal horn of the spinal cord before ascending.
Exactly right. Opioid receptors, and then also C fibers terminate, as I mentioned, that kind of dull pain. I'll do the rest. Nucleus proprius, a little bit more essential to the dorsal horn, Rexed lamina 3 and 4, and this is where most spinal thalamic tract fibers synapse. And then the intermediolateral nucleus is ABI. At T1 to L3 is autonomic preganglionic sympathetic fibers. So you nailed that one. Just remember that name. And then I'll ask Travis, because he pimped me on this one. What was Dr. Rexed's first name?
First name is Dror.
Thank you. All right, so this is the last. So those are the ascending tracts. So now we'll talk about the descending tracts, cortical spinal tracts. So what I have here, lateral and anterior. Let's go to Trevor. Let's talk about these a little bit. So what are the function? Tell me about the course. And yeah, let's go from there.
So for corticospinal tracts, we have a lateral as well as a anterior. Corticospinal tracts control motor function both throughout the entire body. So lateral would be for limbs, and then the anterior should be for control of the neck and trunk. The predominant fibers are going to be in the lateral, like in terms of more number. It's like 90% to like 93 or something percent. And then you have like 7 to 10% of fibers in the anterior. The lateral ones, in terms of their overall course, lateral fibers will decussate at the pyramids and cross over there, whereas the anterior ones won't decussate typically at the pyramids. They will decussate further down the spinal cord at the given level that they're going to be innervating.
Okay, great. Yep, that's exactly right. And then the course, you mentioned that, so we don't have to go through that again, but I thought this DTI image of the brain showed it pretty nicely. So this is, as I mentioned, as Trevor mentioned, the decussation of the fibers at the medullary pyramids here. All right, so this is another kind of quick detour, but another important feature of kind of the nerve roots, exiting nerve roots. So Abi, since your number one is obviously you got before intermediolateral nucleus. Talk to me about the rest of this and the organization. And first of all, let's be more general. What is this right here?
That's the dorsal. That's the dorsal column, basically.
Not the dorsal column
and the axon, or the
R. There's an R.
Yeah.
Root, ramus, something.
Yeah, rami, like a ramus. Dorsal and ventral ramus.
Right. And
so this is ventral ramus. Oh, that's the interneuron. Or
no.
Yeah, that's not.
Think Jeff Zimmering.
Root ganglion, dorsal root ganglion.
Right. Okay, good.
Yeah.
So then what is 2? So they come together, and then what is 2?
All right. So 2 would be the dorsal ramus.
Right. And then 3 here?
3 with the ventral ramus.
That's right. And then, so here, we're talking more about the sympathetic fibers here. So the orange would be the preganglionic. So this passes through the dorsal, the ventral root, into this number 4, which is
for like the white ramus communicants.
Yep, right. And then number 5 after the synapse here, the postganglionic is.
So that would be the gray one.
Yeah, and then 6.
Yeah, so that's the sympathetic chain that's
Yep, right,
arising
exactly.
from the intermediate gray.
Right, and why is it white versus gray?
It's a misnomer. I think they're both of them are actually. Oh, I think it has to depend on the myelination.
Right.
So if you
exactly.
reason out the white ramus would have more myelination versus the gray
Right.
one.
Right, because it's gray. This is going to be postgangliotic peripheral.
Exactly.
All right, almost out of time here. So this is the surface anatomy of the spinal cord. First of all, Abi, what level is this? Do you think? You think this is lumbar, cervical, thoracic?
This is thoracic.
Yeah, I think it's a reasonable. I don't know for sure, but it's reasonable because you have this here, the intermediolateral nucleus, and then none of the posterior intermediate sulcus. So what's number 1 here? What's this called? This fissure. We'll go back down to we'll go back to Georgios. Let's talk about Georgios. This is your slide. So what's number 1 here? This the fissure.
The anterior spinal fissure.
I'll give it to you. Anterior median fissure. And what's number 2 here?
That's the posterior median fissure.
Technically is called the sulcus.
Sulcus.
And then 3 would be.
That's the posterior lateral sulcus.
Yep. And then up in the cervical, there's going to be something. There's going to be a little sulcus here.
Between the 2 fasciculi. I don't remember the name.
Intermediate. And so what do these red dots represent?
The arteries, anterior and 2 posterior spinal arteries.
That's right. So anterior spinal artery, there's 1 of them in the anterior median fissure, and then bilaterally, posteriorly, there's the posterior spinal arteries. And the let's see, I think we're pretty much out of time, but I think one quick as you know, from my roots, just because I don't want anyone to think that I'm going too far into spine, that just pull back into some angiograms. This is something I wasn't really aware existed as a junior resident until I started doing spinal angiograms. But there's an artery here that arises usually from the aorta, and it feeds the first 3 ribs. Does anyone know what it's called? Well, let's start with Halima. Is there a specific name for this artery?
It's the superior intercostal. Superficial intercostal.
No, the supreme intercostal, actually. But yeah, that's just be aware that there is a segmental artery that arises, and it usually branches off to feed the first 3 ribs or so. So I'll stop there before we get to the spinal cord syndromes. So thank you very much, and we'll